We welcome to our future scientist. You are a scientist already. I will start by giving each of you a specific question, and then after that we invite the audience. So can you think about what they have told you? Anja, you're sitting next to me, so you can start. What are the challenges of reaching all future doctors and veterinarians with this knowledge you told about with multi-resistant bacteria?
Is this on? Yes, it is. Okay. That's a good question. So I think the problem is that antimicrobial resistance is quite a big subject, and it's quite a complex topic. And so the first challenge that I think we need to think about is how do we actually communicate towards the medical, the veterinarians, and the auxiliary hospital staff members, as well as the environmental and the veterinarian sectors. So the first challenge is highlighting that this isn't an approach that can be approached in a silo. It needs to be approached from a holistic perspective. And then the second challenge is how do you actually communicate that games are worth investing in? You know, because I think over the past couple of years or forever, we're challenging the status quo where we're saying, hey, in adjunct to the lectures, why don't we also have a game? And so there's a battle with that as well. So it's both this multidisciplinary aspect and then in addition to a new novel way of being taught. I think that answers your question. So
this is about then the mental way of thinking concerning, since this involves the three dimensions of environmental. But what about costs? Money, is it a huge needed a huge financing side for doing this?
For now, what we have done was develop a prototype, and one of the reasons we have developed or piloted this game both in a high-income country and a low-income country was to establish, what are the resources needed. And again, we acknowledge that there are systems in place that make it difficult to introduce a new novel tool. And one of the things is, can we develop an intervention that can be addressed regardless of socioeconomic status? So everyone almost has a phone, everyone has internet. Definitely there are challenges, and we've seen it in our analyses where we look at what are the challenges in making it applicable. So in Zambia, for example, we have something called load shedding, and that's where you have no electricity for a period of time. And when you have that, then there's no internet as well. So that is a big challenge there. So it's not necessarily the monetary things, it's the resources available. But in order for us to have something that can be developed and used in a high-income country and a low-income country, we thought, well, a digital option is probably better than a physical escape room, because that was another opportunity to create. But for now, it's limited to what are the resources and making use of the resources that are already available in different contexts.
But for the practicing doctors and the future doctors, why is it so difficult to have them to get patients taking the medicine according to the prescription?
So I think that's a little bit of a difficult question to answer because it's got to do with how patients are being taught. And so I think in medical school, in veterinarian school, okay, I'm not a vet, but what I'm assuming is that the people are the ones giving the antibiotics to their pets. But one thing that we're seeing is that doctors and veterinarians are responsible for responsible for prescribing these antibiotics. And if they don't know what the right dosage is, what the right microorganism is, then that problem will continually be fueled. And so it's more of how do you communicate, again, the role of the prescriber and how can they understand the importance so that they can then communicate it to their patients. And so when you're at the doctor and they tell you just take antibiotics and they say 3 times a day, are you taking it breakfast, lunch, supper, or are you taking it every 8 hours? So there's a difference in nuance because someone can break up, have breakfast at 8 o'clock and then have their first lunch at 10 o'clock and then their dinner at 4 p.m. And that's when they take their antibiotics, but that's not correct. And so it's how do you, as a prescriber, communicate the correct duration and dosage and time of taking the antibiotics, for example.
Thank you, Anja. You know a lot about this. Yeah, great. Nicole, you are also working at the human body, but from different perspectives. I guess there are a lot of challenges in your field. But what has been the biggest challenge when approaching a microbiome analysis? There are billions of the microbes in this
Yeah,
areas.
there's a lot.
Yeah.
There's a lot. I think so far, and I touched upon it in my presentation, is that there's a lot of information out there on different ways, different methods, and different methods, as I said, do different things. And there appears to be somewhat of a limit of understanding to what these methods actually do and what is appropriate to use and what isn't. So there is a lot of noise out there. And not just in popular science, but also in scientific literature. And so far, my biggest challenge has been sieving through the noise to find the information that can actually help ground my results in statistically, let's say. Yeah.
Do you think, what is the time frame for reaching the goal of identifying something that can be helping for the finding cancer? Is it 1 year, 5 years, 10 years?
You mean once we identify bacteria,
Yeah,
how we can
to find if because by now you are not sure that you will find some markers in the biome in the intestine. You think you are quite sure that you will find that?
Well, you're going to have to wait to see my published articles for that.
Exactly. You expect to find that?
Well, I will cite to you my co-supervisor Matteo, who likes to say I am agnostic. I choose to wait to see what the data tells me. If there is, that's great. If there isn't, that's great. We'll find other ways to find ways to help people get understand their bodies better and understand their potential risk for cancer better as well.
Thank you. Victoire, we are then in really another part of the medicine. What is the most important challenge in your future work to succeed with this form of treatment on a larger scale?
The challenge is also the proof of concept of the fact that what I am doing is a good idea. Some days I wonder, but in the end it is. And it is that the main idea is that each patient's environment is different. And that's why the treatments don't work the same. And the problem I have is that in culture, each samples are different and the treatments don't work the same. So it's very difficult to make generalizations. But that also means that we find more and more interesting behaviors of those cells. They will start invading in ways we haven't planned, and they will start communicating with each other. And it's very, very mind-blowing to see how they adapt to those changes of environment. But the main challenge is the variability. Yeah.
Thank you. Torgeir, mental disorders. Why are people with a mental disorder much more inactive than other people?
Yeah, it seems like it's the mental disorder that makes it challenging to be physically active. We have some data that where we establish that they want to be physically active, they are motivated for it, but they need some supervision and some guidance and some appointment to be physically active. So it seems that it's the mental disorders which makes it difficult for them to be physically active, but they want to, which is kind of interesting. So that's why it's really important to do some more research on how we can provide more treatment with exercise.
But isn't this valid for all the others of us? I think I can recognize myself in what you describe. And until now, I don't have a diagnostic any mental disease. So what? Yeah, is it even worse for them, or harder, even steeper curves to walk for doing it?
Yeah, it seems like it's like then you are not active at all for a long time. Then maybe suddenly you are a little bit active, but the people the reference group who has not a mental disorder, they are like some activity all the time. Yeah, we are talking about just going to kind of the store, and you don't want to do that because it's making you exhausting. Yeah.
And yeah, there are probably many sides of this we'll discuss further. Thank you. Marius, now you have heard 4 of your 14 candidates. What is your impression? What do you think?
So I'm immensely impressed by their performance tonight. I think they deserve the pause.
Yeah.
And I think there are 2 things. So one is it shows the importance of being able to communicate the project you're doing, the research you're doing. And I think they showed great example of doing that today, making it publicly available for everyone to understand what they're doing. And I think that is important for our mission as researchers, to be able to communicate that, because they are going to write a thesis in a few years. And that is probably going to be read by a handful of people in the world, sorry to say, but it's technically advanced. It's for the experts. But in there lies wisdom, in there lies results that should be available to everyone. And that is why it's important to be able to communicate that. And I think that is something we need to train them on, like they have been done over the past 3 months. It's a skill that needs to be practiced and developed.
Yeah, and all these perspectives we now heard about, these are, I guess, all of us listening to them. We, in one or the other phase, part of our life, we will come in contact with what you now just told us about. So this is concerning all and everyone, or am I very wrong? No? Yeah. And some of we have already been close to, for example, cancer. That's so common. But now I can't see you here because, or I see just a few of you because of the lights is so heavy. Now we're inviting the audience here to give us questions. Here's a hand first, I can see. Yeah. Nina will come with a microphone and give a short and clear question for us.
Yeah. Hello. First of all of you did really good job today. My question is directed towards Alia. That you explained very well that how the different ecosystems are so interconnected. This whole nexus of environment, human, and animals. And then you talk about your app that seems to be a success in training doctors or medical practitioners to be aware of what AMR is and how to work toward it. My question is, how do you emulate this interactive, let's say, app? What data do you use, and how this data fits into the picture of training the doctors or practitioners? Yeah.
No, thank you. That's a nice question. So our app at the moment, our prototype, is based on a couple of levels, and we've piloted it amongst medical students in Norway and in Zambia, and then the veterinarian students in Norway. And so what we have done is our app has 3 or 2 levels. The first level is the background. And the background level is based on all the literature about what AMR is, how it happens, why it's important, and this importance of this One Health interconnectedness or this One Health approach. And so all of that is based on pre-existing literature. And then the levels are, or level 1 and level 2 are clinical case scenarios. And with that, we've worked together with clinical microbiologists, infectious disease doctors, veterinarians, doctors, education, pedagogy kind of people. And we've gotten all of their inputs about, what is a case that is simple, but also important that you will most likely see in your everyday practice. And so, for example, our clinical case in the medical scenario is a urinary tract infection. And how do then you go about treating? So it's a simulation of you have a patient, you interact with the patient, you get the results, you see the results, you interpret. And so it's not just simple recall. So we're not just like, oh yes, let me go back 2 rooms and then analyze. It's, okay, so this is how it happens, but now I have to apply that knowledge. And through that, they kind of progress through the rooms based on what knowledge they need to build up on. And then they have to escape the room. And from that, then they learn the clinical core competencies that is from the World Health Organization, the Food and Agriculture Organization, and the veterinarian aspect of that as well. So we're using both, we're really trying to take into consideration this multidisciplinary aspect. I mean, it's really ignorant in a way to say, yes, I by myself, I'm going to do everything and create this case scenario. But we're also trying to, at the same time, encourage other participants to really understand why we need a veterinarian to come and talk about human healthcare, and why then humans need to be interested in what kind of plants they eat, and so on and so forth. So that's the approach that we've taken. And the veterinarian case, for example, is an ear infection in a dog, which I don't know if you have dogs, but sometimes that's kind of a recurrent thing that they have. Yeah, I hope that answers. Yeah, okay.
Yeah, thank you. That was a good lesson. More hands?
Yes,
Oh,
thank
yeah,
you for
then you
very
will-
inspiring presentations.
You will be next here, another person too. Please go on.
Yeah, I was trying to reflect on my own relationship with the exercise when I listened to you, Torge, and there's always the issue of relapse. So the question I have basically is something that we all struggle with: how to endure sort of what is not necessarily experienced as a positive state of training when you would need to be reaching this high level of intensity. It's sort of kind of unpleasant. So you need to find something that keeps you going even without having a mental disorder. So how do you address this issue of relapse? So you can demonstrate for yourself, okay, I did it once during 3 months, but then the 4th month come and you feel great about yourself, and suddenly you're back in your old bad habits.
Yeah, I think I got your question right, but you can say if I heard wrong. But it is some of the issue that we are addressing, because we know that the 3 months of this high intensity training works, and then it's kind of difficult to kind of increase or get some more beneficial outcome of the exercise. You see that you have this really high improvement for 3 months, and then it kind of stabilizes. So it needs to be kind of a habit, but it's difficult to fall in love with that kind of habit. So that's a really good question. It's really difficult because maybe the question should be, what should you do? What kind of exercise should you do after that for a period of time, for example, in order to get the motivation back for a new 3 months period? Because if you train for 3 months and you don't kind of do that type of interval training for 1 month, you don't lose the 3 months of improvement that you already have gotten. So that's some of the things we are addressing, and we're also going to follow up patients after 3 months. And then we're going to follow up them after 1 year and talk to them and see how their activity level had been. But it's difficult, yeah.
Marius, is that a new research project?
Yes, it could be, yeah. No, and I think it doesn't only address or relate to physical activity. I think it relates to a lot of habits and lifestyle aspects that, well, the bad things feels more comfortable than the good thing. Yeah, so I was actually thinking, about your project. Could we do gamification in some way here? Make it more attractive, addictive to do the health promoting things? I don't know.
You have seen gamification by bicycling, to be on a bicycle connected into some gaming. The more you bicycle, the faster you can move through the gaming.
Yeah. So there has been a few research projects on that, to my knowledge, and but I still think we need to like crack the big nut here, because it's a really challenge in our world today.
We had a person or a hand here. Yeah, you are.
Så hvem var det som Randi snakket om?
I don't know. You have to raise your hands once more. Yeah, please.
Yeah. Really, all presentations were really engaging, and I enjoyed listening to them a lot. My question is for Anja. You mentioned this One Health approach where you look at the environmental sector, at the animal sector, and also, of course, humans. And I'm wondering, why is that so important in the case of antimicrobial resistance?
Yes, that's also a nice question. So we talk a little bit about how antibiotics affect these different microbes, but then these microbes are within each of these sectors independently. And so in the past, we've just been approaching them in silos, right? We're like, okay, a veterinarian will prescribe antibiotics for their dog, and then full stop. And then the doctor will prescribe antibiotics for the human, full stop. But what they don't look at is how are antibiotics used in these other sectors. So we know, for example, in animal husbandry, so that's like growth promotion, they give antibiotics in the feed of the animals. And that's just because they want bigger, beefier cows. And they do the same for pigs and chickens, and they just give it as preventative. And we've seen it in a couple of news articles last year in Norway, where they've had to recall a lot of meat because antibiotics were prescribed, they were given, and then the animals were killed early. And so that's one aspect, that like the animal or the environmental sector both gets antibiotics, and then we as humans will eat them, and then we get some sort of resistant antibiotic, or we further progress the antimicrobial resistance within our own bodies. And so all of these things are working they're very interconnected. And it's the same, for example, there was a paper that came out last year that was quite frightening. And again, I don't know how many people own dogs, but they were talking about how 2 in every 10 household owners with dogs, they're the ones that get urinary tract infections from their dog. And so that's quite a scary thing, because you're like, okay, well, if I've got a urinary tract infection, I'm going to the doctor, I'm getting the antibiotics, but my dog isn't, then I'm just going to go back and get the same infection from the dog because it's the same microorganism. But now that microbe has got resistance to the antibiotics that you've taken. And so it's this close link that we're not necessarily looking at. And it's the same with plants where we use antibiotics in the soil for the feed. We use it for prevention. And it's, again, antimicrobial resistance is not only about bacteria, it's also about fungus, viruses, and parasites. So, you're taking something to prevent fungal resistance, but for plants, but that's something that will get back in your own system. So approaching it and understanding how the human affects the animal, how the animal affects the humans, and it's all interconnected. And it's a new approach, I think, now that we're considering, which has previously been, oh, we don't need to think about animals, but we do. Yeah.
There was a hand here. Yeah, and here. Okay, first then and then here. Yeah.
Thank you very much for very inspiring talks. I think it was marvelous. I'm an oncologist, and I have some questions. But at first, I thought that you two could collaborate. You should collaborate because everybody should collaborate, actually. But you two have this antibiotic and microbiome is closely interconnected. And for example, if you get immunotherapy for cancer and you take antibiotic, the immunotherapy doesn't work so well, for example, because it kills something that helps your immune system. So that takes me over to you. You're Nicole? Nicole. So you say that you are trying to find some markers for cancer. Is it some special types of cancer? Is it cancer in general? I mean, there are so many different factors that makes cancer develop, like, for example, smoke-related cancers or inactivity or your nutrition-related cancers. Do they all have the same microbiome profile? Are you going to look at those different profiles? That's one question, and then I have a question for you. Yeah, François. Victoire, yes. When you do the screen with your small tumors, okay, your small tumors don't only have tumor cells, okay, so they have many different. So how do you know which cells are affected by the treatment you give, and how do you know that this will actually work in your patient? And that's one. And the other one is when you grow the tumors, are they from the first biopsy or are they from the metastasis? Because the tumor changes as it evolves, it changes, and maybe if you test the primary tumor, it will not work. Your treatment will not work in the metastasis. Okay.
Okay, that was 3 questions. Yeah, are you pointing to Nicole first?
Yeah, I'll
okay.
start. My
and
answer
you take
is
the
brief.
2 others afterwards. Yeah. Question 1.
That was a lovely question, and you're absolutely right. There are a lot of factors that influence cancer, and we do our best with our models to account for them as much as we can. Now, that being said, to answer the first part of your question, yes, we look first at cancer as a whole, just to see if there is a general trend that can be seen. And then, of course, we break it down into individual cancer types to see how that changes, because, of course, breast cancer is very different from prostate cancer, which is different from colorectal cancer. There are sex differences also that come into play, and age is a big important factor, and as you said, diet is an important factor, and we try to analyze these variables as best we can and include them in our model as best we can to get a picture that is more or less complete. But you'll have to you'll have to come back in a year or so when we work on our articles a little bit better to give you a full answer on what we see exactly. Yeah, that's it for me actually.
Then I can, is it work? Yeah. Then I can keep going. So your first question was about how do I know I'm actually treating cancer cells, right? So I showed a couple images of stainings of markers that will tell me that those cells that are positive to these markers are cancer cells, but you're absolutely right. And in my small tumors, as well as in the patient, a cancer is not only those aggressive cancer cells per se, it's a whole support system. As Nicole mentioned in her image, it's a city. It's a city that has its way of communication, transports, and whatnot. The way I know that I'm actually treating cancer cells is that once I get the tumor from the surgeons, I will grow it in a specific cocktail of components, chemicals, inhibitors of certain pathways that those other cells use. So I make sure that over time, the only cells that are able to grow and survive are those cancer cells. Secondly, I forgot. Oh, yeah, thank you. So, first, we're starting on the ovarian cancer, and the ovarian cancer is detected very late, and the metastases are on the connective tissues of the abdomen, on the omentum and the peritoneum. So these are the tissues, the samples we get from ovarian cancer are metastases on these tissues. It is actually surprisingly rare to have ovarian cancerous tissue per se from ovarian cancer. And that also means these tumors are exceptionally aggressive, and yeah, that's one thing. So the line between primary tumor and metastasis in ovarian cancer is kind of blurry, but we're also working on prostate cancer, and in prostate cancer, then it's a lot more clear to have a picture. On a quick side note, we have patients in our ovarian cohort that we have sampled from the surgery, the primary surgery, and some of them have unfortunately relapsed, but that means we have samples from a relapse. And we can expect that these two will have very different profiles. On the prostate side, the primary tumor will be in the prostate, and the metastasis, for instance, can be on the bones. So here it's more of a logistic question that I am not good enough at communication to convince someone to get a drill to their bone just because I'm curious. So that's the main issue we have right now. If we would want to take metastasis tissue, for instance, for the prostate, is that it's very tricky to get. The primary tissue is a lot easier to get.
Yeah.
Thank you for the question.
was-
That was great.
So we have a question in hand here. Yeah, please.
Thanks to all of you for great presentations. I also had a question to you, Victoire. I'm also a doctor who has been working in oncology, and I'm interested in this clinical study. Generally speaking, when we have a clinical study, the control group at least should not get anything less than the best treatment such as we know it today, unless it's a very early study where you have a very bad illness which is untreatable. Excuse me. Do I understand you right that in this study, your patients who are involved in the study, they get that specific treatment that you have analyzed in your organoids and not anything else? Or do they get it in addition to the general best known treatment as of today? Because this is an ethical question, and I'm sure you've been working through the ethical committees to get it approved of. But after all, ovarian cancer is not 100% deadly at the stage like your patient had. And so the prognosis has improved a lot with several of the medications that you showed us. So if your patients don't get that treatment and they only get what you have decided in your laboratory is best, is that best for the patient or isn't it? And after all, these organoids, they are not a person. They are a group of cells where you have isolated mostly cancer cells. But after all, in the body, there are lots of cells and lots of connections. You don't get the neurons, you don't get the immune system probably. There is the communication from your brain and from everywhere. So the environment that your cells are in is not the same as in the body. So it's quite risky, but I'm impressed. I mean, I know there have been studies like this going on for a while, trying to isolate cells, cancer cells, and try out their resistance or the sensitivity the same way you do on bacteria. But the human body is a lot more complicated, so you've got quite a challenge.
I do. Thank you. I'm very happy to have oncologists and gynecologists because it's very, very valuable feedback on the other side of the mirror, if I can say. You're completely right on the fact that, yes, this is a tumor, this is not a human body. And this has been a question that has been mainly tackled through very interdisciplinary work, a lot of engineering. I don't know if you heard of organs on a chip. To make it very clear and fast, it's what I do. Those clumps, tumors, 3D structures, and they will be used from different tissues. So for instance, I can have them from the cancer, and if I want to see, oh, but actually, if I want to give this medication and it goes through the gut system, is it going to reach the tumor? Then I do these clumps of gut system right above, and then I link them. It's a whole hydraulic engineering system. And these, it's a bit nerdy, but these are a lot more representative, and our pretty much only other option is animal testing. And this is also, in the context of sustainability, a big, big issue, because in addition to the ethical aspect, it's so much waste, it's so much, resources that are used for studies that might not necessarily need them. So I'm kind of at an in-between point. And the step under is what is called cell lines. So cancer cells that have been immortalized for sometimes 40, 50 years, and that we cannot really say they're representative of patients nowadays. For the ethical aspects of the trial, this is also a very good question. And of course, as you said, this is not a trial when we're going to give placebo, because we're going to jail. So that's not good. So they will get the standard pipeline of treatment that is given at St. Olaf. I don't know if you work at St. Olaf?
Have been for 40 years, yes.
Oh, wow. Yeah. Then maybe you know Guro Aunes. She's the surgeon we work with on this trial. And it has been very good to have some clinical input on this. This issue you mentioned, one way we have started thinking about it is with another PhD project, which is a more computer project that is designing a model, AI model, that is being trained to predict these most efficient, which would be the most efficient treatment, again, but with a whole larger data set and a lot of different predictions. For instance, I base my predictions on the tissue we get, but he would base it on, for instance, the BRCA status, which is a common marker of some kind of aggressiveness, to make it very simple. Yeah, so that's one way of dealing with it. I hope I answered somehow a bit your questions.
Inger.
Cancer cells are very much like bacteria. They also grow resistant, don't they? So
We have to have the microphone because the people in stream won't hear that. Oh.
no, I just wondered that one question about if your patients in the treatment group who get your designed medication, if they also get some other medication, or do they only get that one that you have found to be sensitive in the laboratory?
Right now, we're at the preclinical stage because, as you mentioned, these studies have. This field is very, very innovative, which means we are discovering new things every day, and it needs a lot of validation. It's maybe 5 years that this field has been going on. So we're at the preclinical stage. I tried explaining how what I do and what I discover in the lab would be helpful for the patients that we get at St. Olaf. Yeah. I would need the surgeon to answer very precisely.
Okay, this was very deep in the medical treatment. But what we can we who are not specialists, what it rises up here is a lot of dilemmas. It's dilemmas between how to give the aim you, Marius, put up to give the best treatment, the most sustainable treatment. We have a lot of gains, and I think that what we hear now, there's a lot of, especially maybe in actually in all the fields that you are working, because for the mentally ill, there is also a dilemma. How much can we expect from them? How much responsibility are they to take for their own health? Are they able to take that responsibility? And we can ask ourselves as well, as some pointed to. And Marius, I would like you to comment on this, because you gave us the overall picture, and for all of us who are the audience, we are, of course, also very concerned when we go to the GP or the fastlege, and we meet the specialist, not to talk about if we are hospitalized and we are having the treatment with cancer. Because the capital we have, which is the most crucial, it is the trust. Do we trust the medicine system that is really, or if it's experimental treatment, and the trust, there's a sort of a psychological contract here between the citizens in the society and what society can offer. A lot of dilemmas. How can you are a researcher now, and you are leading this huge strategic research field. How will you navigate in this landscape?
Ooh, that's a big question. So first of all, I mean, I think the essence of sustainability in healthcare is all about dilemmas. And it's probably why we are moving in the wrong direction and has been for many, many years. It's because we constantly want to give the best treatment. As doctors, we constantly want the best for our patients. And the public expects no less. That's sort of the contract between us. In a way, in the healthcare system, we manage a lot of resources on behalf of the society. And we're supposed to manage those resources to the best of the society. But this is quite difficult to sort of safeguard and do when you meet an individual patient. And I think that's sort of one of the dilemmas that a lot of doctors are facing every day. And a lot of these, and a lot of the forces behind driving, for instance, overuse in our healthcare system. We want the best for our patients. The patients expect the best. And I think when, for instance, in a general practitioner's office, a fastlegekontor, when you are squeezed on time, for instance, you don't necessarily are able to communicate that this is not necessary. If you don't have the trust of the patient, prescribing antibiotics, if you say take it 3 times a day for a week, if the patient doesn't have the trust in you, then they don't necessarily follow your prescription. So having that trust is really important in doing what we do. And I think to some extent this trust relationship between doctors and patients, the healthcare system as a whole and the patients, is on the verge of not probably breaking down, but it's diminishing a little bit. And I think some of what we see in the media and in the public, that we have long waiting lists, people experience not getting the health care they need, and so on, is also driving this trust level down, because it's sort of we are not then managing the resources correctly on behalf of the society. And this is sort of a wicked spiral as well, because if people don't trust us, we can't give the correct advice, they don't follow our advice, they may be demanding more services than they really need, and it's really hard to resist. And then, I mean, the queues get longer because people are doing unnecessary examinations and so on, and they get harmed, and then that's additional examinations and so on. But so I think we need to sort of break this spiral in a way, and that's a tough dilemma, and it's probably for the politicians.
But what can be needed measures for being able to start that process or something? Where to start? What can be the? Is there any simple measure to take to start?
I don't really think it's any simple way to any solutions, but I think we need to, as a society, move to more a stronger focus on prevention. That's definitely something we do, and I know they have been talking about it, the politicians, for 30 years or something, that we need to do this, but it's really not been followed up. And I think part of it's also why it's not working is because it's been on an individual level. So you need to get yourself together, you need to exercise more, you need to eat more healthy. And we all know that's really hard. And when all other forces in our society is working in the wrong direction, in the other direction, we are driving more cars instead of walking. We have elevators, we have escalators instead of just stairs. Just these simple things about our society, like, and the food that we get, the cheap food is not necessarily the healthy food, and so on and so on. So at some level we need to this needs also to be moved up to a high priority on the national level, and we need to.
At the system
It's a systemic
level.
thing. Yeah. Yeah.
Audience, I'm sure that a lot of people here are. Yeah. Nina, where are you? Ja, og her det en foran her. Ja, start there. Yeah.
Okay. My question is for Nicole. I'm not in the medical field, so my question is more practical. If it turns out that your test is 100% effective in determining if someone is going to have cancer, how often does the gut biome change? How often would you have to take this test to know that you don't have cancer, or to determine if you will have cancer?
That's a very good question. The point of my research in its application in the field isn't so that we can then shotgun sequence everybody's gut microbiome, because that would be very unsustainable indeed. It's more under the optics of, say we find one bacterium. In an ideal world, we will find one bacterium that we can link absolutely, without a question of a doubt, to cancer. And what we can then do is do cell cultures and see if a patient or an individual has that bacteria alone, or how much of it. And in that case, then we can better monitor the situation, which wouldn't require having a whole microbiome vision of everything that's going on in their little city. I hope that answers the question.
Okay, da har vi ett der, og så har vi en her til slutt. Ja.
Well, I will be short because I don't actually have a question, because that was partly answered by Marius's comments. But I have a comment to you. It has been a wonderful experience sitting here tonight, listening to you before the break, thinking that I understand, because you were able to present it in such a way that even a person being an expert in a totally different field could understand. And then when it came to the panel talk, you realized that you don't understand anything. But what you do understand is that the candidates are fully capable of answering in a highly qualified way. Thank you so much.
So great presentations. So I'll not bore you with your core courses and what you do. What have you planned? You are working on interesting projects which are highly innovative, and that's why you got funded from NTNU Health and Life Sciences. But what would you do after this project? I mean, have you thought of setting up your own companies, become entrepreneurs, and take it to the next level, or live your life in the lab till you die? What is the plan?
Short answer from all of you.
The plan is survive. I have short-term expectation. I would say some of our fields are a lot more marketable than other. Probably Anja, Torgeir have already kind of something developed that could reach the right public, while some of us our clients, the people that would be interested are more in the medical field. But what is great is that around these big projects we have are actually a lot of satellite things, optimization, design, and everything, and that can be very, very relevant for collaborations and setting up something to actually live for.
Never ending indeed.
Nicole?
Eternal funding. I second what Victoire just said, survive, mostly. I personally really enjoy academia because of the freedom to actually explore, as opposed to when you work in a more privatized companies, you have to follow the rules a little bit more in a different way. But you know, in this life, in this climate, who knows where we'll end up? Hopefully employed. That's my...
Anja?
Okay. Yeah, for me, I think it's, you know, I've already kind of proposed the next step, which is right now we've developed something for medical and veterinarian students. And, you know, we have already been asked, you know, what about the public? What about auxiliary hospital workers, so nurses, pharmacists? And so these are prospective steps. But I think not only that, there's an idea, so to speak, to say, yes, a digital escape room as a concept works for this topic, but at the same time, it can be expanded. And I think Marius had also like hinted about it, like gamification can be applied to these different other contexts. And I think that is an exciting idea to see where we get funding and how we can take it from just a prototype and an idea to how can we now address the public, how can we address the private sectors, the public sectors, these different environmental farmers, veterinarians, and so on and so forth. So fingers crossed. But if anyone feels free, just
call
give
you.
us some dollar bills.
Torgeir, you have a microphone, yeah?
Yeah, it's difficult to follow up.
Will you run on the treadmill?
Yeah. My plan is, of course, survive, eating oatmeal every day. No, I really like academia. I worked in clinics, training clinics at St. Olav's Hospital for 3 years before I started my PhD. And I just really want to... I'm so interested in the exercise as a medicine prospect, so I just want to continue the work on having that more implemented in our healthcare system and make it more sustainable. Yeah.
And Marius, you have a job that you have got for 5 years.
Yeah. Well, I also plan to survive. Yeah, you were asking about entrepreneurship. Yeah. Yes, I'm not sure if I personally want to sort of venture down that road, but I think it's really important to have that mindset also in terms of turning what you do in research into something practical that can be used in society. So it's a really important aspect. And although I'm not going down the entrepreneurship road myself, then I'm really encouraging others to do it. Yeah.
Oh, that's a good idea. Okay, then time is past 9 o'clock, which is our frame of time for this evening.